Hello, everybody. Good morning if you're on the East Coast. It's still good morning if you're on the West Coast as well. But anywhere else, maybe good afternoon to everybody. And Tuesday VMR. Very excited to again co-discuss with my great friend, colleague, Dr. Kirtan Patolia. And we have a special case that's brought by Samba Siva. Before we get underway, I'll have Kirtan unmute and then Sambasiva unmute afterwards and just say hello.
Of course, thank you for the introduction, Dr. Singh. I'm excited as always. And now with Ravi discussing on Tuesday, I get the chance to discuss with him every alternate week when I'm not on service. So it's kind of like a habit now, that every other Tuesday I will be discussing with Ravi. So fun. And yeah, Shiva, how are things going with you? Thanks for bringing us the case today.
Yeah, I'm really excited for the session today. I think it will be a great session.
Perfect. Thank you, Shiva. And then I can pass the mic to Dadmaya, who is helping with the teaching. How are things with you, Dadmaya?
Thank you very much. Very looking forward to this. Yeah, I'll be doing teacher points.
Awesome. Thanks, Ajmal. Simi, your background seems to be different today.
Yeah, hi everyone. Just in a different room today and very excited for the discussion and case today. Looking forward to the session.
Of course. Thank you, Simi. All right. Well, friends, if everything is all set, then Shiva, we can pull up the first aliquot.
Yep, sure. Just in terms of standpoint, I have divided the case into six aliquots total. And the first aliquot I'll start with. This is a 50-year-old man with a history of alcohol abuse, presented for evaluation of difficulty speaking to the emergency department. I will stop here.
Wow, a great place to start, Shiva. And we will clarify eventually with Shiva that what is the time course, because we know that in neurology, whenever you are dealing with a possible neurologic symptom, you always need two elements, right? That what is the localization and what is the time course, which helps in framing up your differential. So in this case, so far we know that this is like a middle-aged gentleman who is presenting with difficulty speaking, right? Now, when you think about how do you speak, then just like if you close your eyes and if you ask yourself that if let's say you have your friend in front of you and you want to say them that hi, how it's going, what it will take for you to do that, right? So first your brain has to generate an idea, right? And like diffusely speaking, we are talking about your cortex has to come up with the idea that you need to say something to someone, right? So if there is cortical dysfunction, you won't be able to frame that idea itself, right? Then after you have framed the idea, your speech centers have to kind of activate and they have to relay the signals to different parts of the brain, which helps in coordinating the action of your facial muscles and the tongue, which will help you speak, right? So if you think about the speech parts, we are primarily worried about the Broca's center, right? Which is in the frontal lobe, where the signal has to be generated that you need to speak something, right? Then Broca's area will coordinate with the subcortical structures, primarily your basal ganglia and your cerebellum, right? Because we know that basal ganglia and cerebellum helps in coordination, and that is probably the reason why we often say that if someone has, let's say, cerebellar dysfunction, they often have dysarthria, right? Often people who have basal ganglia disorders, they also have stuttering speech, right? So this kind of tells you that cortex has to generate the idea, it has to relate to the subcortical structures, and then finally your subcortical structures kind of integrate all the data and relay it to the cranial nerves. So your cranial nerves 9, 10, 11, 12, all of them have to function in coordination in order to match your breathing pattern, in order to match how your tongue is moving, right? And then finally, when all those signals are relayed to your tongue, your vocal cords, they have to like grab those signals. So you could imagine if something is wrong with the nerves or something is wrong at, let's say, the neuromuscular junction, where you are able to trap this signal, you can have difficulty in speaking. And then finally, the end pathway that your vocal cord, your tongue, if something is wrong locally there, let's say there is some kind of inflammatory process going on, some kind of mass lesion, some kind of space occupying lesion, right? Then you could imagine that your vocal cords won't be able to generate the noise by opposing with each other, right? Similarly, if your tongue is not in the appropriate position, maybe let's say you have profound swelling of your tongue. or maybe there is something else in your oral cavity which is not allowing your tongue to move properly. Let's say your dentition is bad. So you could imagine that any kind of structural problem at the end organ can also impede your ability to have like this ability to speak properly, right? So that is why we went from all the way like very fancy structures in the brain to all the way very like simple things in the oral cavity, right? So we need to evaluate all of this, and time course will be very helpful, right? That if something is happening all of a sudden in matter of seconds, then you prioritize the process going on in your head. If something is more indolent, slowly growing on, then you think about something localized, right? And of course, other symptoms will help us as well. So this is just a rough framework, and now I can ask Dr. Singh.
Absolutely wonderful journey through the neuroanatomical network, Ketan, like when you're trying to identify like the structures that are required in speaking or articulation. But we can break this down into terms. There's certain terms when we go to the bedside, we ask like, is this a problem such as aphasia? Is this a problem such as dysarthria? Is this a problem number 3 as dysphonia? So is there a problem in language and processing, in the articulation, and then sound production? So I'll give you an example. Sound production, is this something, like you mentioned, something physically within the throat itself? With the dysarthria, is there a problem with the neuromuscular apparatus? And with aphasia, is it something then centrally, like you mentioned, in the language processing area? The way to then decipher between that will be the examination. So go to the bedside and then do a mental status exam to see if is this really a focal issue or is this a global issue? Like, so this patient has something which is key that Siva had mentioned, alcohol abuse. I mean, this could be simplistically the patient may be taking in too much alcohol and causing a global cognitive issue, CNS issue, and maybe they're slurring their speech due to that. But I think something more complex is happening here, and we need to get more information. So more elaboration in the HPI and eventually the exam will help us at the bedside to see if we are dealing with actually a neurological issue or something else like electrolytes, is it a substance issue, and so on. Any other ideas, Ketan, before we turn the mic over to
No,
Siva?
all good, Dr. Singh. Let's
All
hear
right.
from Shiva.
Back to you, Siva.
Yeah, thanks for the great framework like neuroanatomical and the correlation clinical. Yeah, coming to the psychedelic part, 2 months prior, the patient was in his usual state of health when he developed and a sensation of throat closing, for which he came to emergency room. He was given a diagnosis of anaphylaxis to cherry juice and given epinephrine, antihistamines, and glucocorticoids with resolution of his symptoms. He had no past medical history and 1 episode of acute alcohol intoxication many years ago. He reported frequent alcohol use of 30 units weekly. His only known allergy was anaphylaxis to avocado, which occurred when he was a teenager. He took no medications except the over-the-counter ibuprofen or Tylenol as needed for his, which he attributed to mechanical pain related to his line of work. On the current day of presentation, he was in his usual baseline. He had not drank any alcohol that day. Snow in his backyard without sustaining any and felt well immediately afterward. Hours later, in the late, noticed a feeling of his tongue, which progressively worsened throughout the day. To speak. In the afternoon for evaluation, they noticed marks fell on the floor of the mouth, and the patient epinephrine and sent to the patient. Reported no new medicines except for the snow that he tasted. Accidental fall here. In the experienced progressive generalized weakness of his baseline right hip pain, which had progressed enough to affect his ambulation to his fall. He reported recent use of NSAIDs for hip pain, although this was not a new medication for him. Additional history obtained for numbness and tingling in both feet to the ankles and tingling of the left great toe, weakness, and a history of persistent left olecranon bursitis. He reported multiple prior episodes of podagra involving the left great toe because of the gout diagnosis, which is contributed to his chronic alcohol use. He had 2 episodes of COVID-19 infection despite vaccination during the previous year and had an episode of shingles approximately 3 months earlier. Family history: his father died of unknown brain tumor, and one of his 3 daughters had acute myeloid leukemia. There was no other rheumatological or neurological disease in the family. He worked as an electrician and coached football on the side. There was no history of travel outside the state in the past 2 years, and he was sexually monogamous with his wife. I will stop here.
Okay, so I'll kick it off with this aliquot here. So it's interesting. There's a whole sequence of events prior to this happening. So shoveling snow in itself is a very arduous task. And then he suffered injury. I mean, I usually correlate shoveling snow with maybe cardiovascular stress and maybe due to the cold weather, vasoconstriction of the coronary vessels and likely acute coronary syndrome. But here we have a fall and he noticed fullness. Now we were hypothesizing that during his speech process, maybe there's an interruption somewhere. Is it within the CNS system, within the cranial nerves, as a physical manifestation that's impairing the ability for vocal cord function and so on? But here we do have something in the tongue. So articulation and sound production can be impaired due to this. So this will need further workup. The exam will be helpful to see exactly what this fullness is. Is this a lesion? Is this swelling? Is this an ulcer? So we'll kind of put that on the back burner for now. And then we go back 2 months ago. So 2 months ago, seeing the backstory to what's happening. And he's had this tongue swelling since then and this throat closure. And what's interesting is, yes, then again, this thing has been slowly progressing. It's not like suddenly he showed up and he's having difficulty speaking, but this is a progressive chronic issue that's been happening for a few months. And this story of anaphylaxis is interesting. I mean, this would be an acute presentation. Somebody takes something inhalational or something orally or something that could be topical, any sort of materials that could trigger an anaphylactic response. And that can cause immediate throat swelling, hives, and so on. But it did resolve. He was given the appropriate treatment for this as well. So at this point, what's interesting is you relate this articulation issue, tongue, and then this unusual story of anaphylaxis. Does this have relevance at this point? We don't know, but I'm definitely going to stick a pin in it and track it with the rest of his examination. So what do we look for? So certain labs we may look for with this anaphylactic history. And then I'll turn the mic over to Kirtan because there's some other review systems which are interesting here. How can you integrate this with what he's presenting with? Over to you, Kirtan.
Right. So no, Dr. Singh, I will just take from where you left that in the first episode we were discussing that we want to localize this problem where it is going on. And like Dr. Singh said, right, that if it's a diffuse process, you expect other symptoms. Imagine if someone has problem in the Broca's area, often you expect them to have like aphasia, which we are not seeing, right? It's just a difficulty in speaking. It's not like the grammatical errors are there, right? We don't have any consciousness issues going on. Patient is alert and oriented, right? We didn't hear, at least as of now, that there is like focal deficits, like there is weakness. We didn't hear any of that. So that kind of makes us wonder that maybe the process is more distally, near your final end pathway, near your mouth. And we were thinking that what could be going on at the level of vocal cords, what could be going on at the level of tongue. And now we have some idea that the tongue is swollen. And we will, of course, verify that on the examination. But you could imagine that when one part of your body is swollen, it is very possible that surrounding area might also be swollen. Why? Because of the contiguous spread of the same pathology or because of the underlying systemic process which has proclivity to affect your mucosal structure. So if this gentleman's tongue is not doing well and it is swollen, one might say that is it possible that even the pharynx and larynx, including vocal cords, might be swollen to some extent? And maybe it's combination of all of that which is making it difficult to speak, right? So if on examination we confirm that the tongue is like grossly swollen, then we will have our answer, right? And then our task becomes that what kind of framework we will keep in our mind to frame that how can you have swelling in your tongue, and based on that we can get the labs, right? So if you just think about this tongue swelling as of now, either it can be coming from something external or something internal, right? What could be something external? So let's say if you have some kind of trauma which is visibly evident, like this gentleman fell, right? But we are not worried about this fall being the sole result of everything, because even 2 months ago patient had developed tongue swelling when he didn't have a fall, right? So maybe we are saying that this fall somehow triggered that process, but the underlying cause is something else, right? But in some people, you could imagine that they have trauma from outside. Let's say they had some viral infection, they have some vitamin deficiencies, they ate something which was very like hot, and maybe they ended up injuring their tongue, and you can have localized inflammation in the tongue, kind of like glossitis, and you can have tongue swelling, right? But we didn't hear about anything obvious. Like we didn't hear that patient was eating in a restaurant, something like very hot, and then this happened. Patient had some severe vitamin deficiency which ended up causing this. We don't have any of those data, right? We didn't hear that patient had a seizure episode and maybe then bit his tongue, right? So I'm more focusing on something which is coming from inside, right? Which could be causing this tongue swelling. So it's in medicine, sometimes it's important to come up with a normal tags. You may not refer to as the final diagnosis, but tagging it something helps you generate the differential diagnosis. So you might say that can this person have kind of like anaphylaxis going on, right? Localized anaphylaxis. Anaphylaxis doesn't have to come always with systemic signs and symptoms, right? And by anaphylaxis, I'm referring to something we call as the angioedema. That can you say that this person has maybe angioedema of the tongue, maybe angioedema of the larynx and pharynx, right? And if there is angioedema, simplistically speaking, we are talking about excessive activity of the bradykinin, right? Now, why bradykinin is so active in those regions and why it is causing swelling, that is what we need to figure out. And that is where we look for variety of triggers. Sometimes bradykinin can be activated by virtue of certain medications. So for example, NSAIDs is one classic example, and ACE inhibitor being the other classic example, that both ACE inhibitor and NSAID have ability to affect the prostaglandin and leukotriene pathways, and they also have the ability to affect the bradykinin metabolizing enzymes, and that is why bradykinin kind of accumulates to certain extent, and you end up causing angioedema. So in this case, it is possible that NSAIDs are exacerbating factor, but of course NSAIDs alone should not cause this, because like patient had one episode again 2 months ago, which is like very biggest clue which we have as of right now, right? So this is just two common example which I give, medication. But of course, there are so many other endogenous hematological disorders which can end up causing this, and we will get to that if we confirm our hypothesis, right? And then finally, I will also quickly touch upon the fact that this patient has numbness and tingling in the feet. Now, of course, like if you are one of the PCPs, you will see this complaint very often, right? So many people have numbness and tingling. It's your job to figure out like how real is this, how serious is this, right? So we will do examination, we will try to figure out is it a purely sensory issue or is it a concurrent motor issue or not, and down the line we will have to pursue like electrodiagnostic studies to confirm what kind of neuropathy is this, right? And we will have to look at the metabolic risk factors. So we know this gentleman has alcohol, which itself is a significant risk factor for neuropathy, and probably the very common cause in someone who is heavy alcoholic, right? But of course you cannot discount other systemic issues, and we will get to that later on. And regarding this hip pain, which is also very curious, that why does he have hip pain? Now, he is not like someone overtly old, like 80 or 85 years old, where you might chalk it down to osteoarthritis. So I'm definitely wondering in my mind that what could be going on in the localized osteoarticular structure there. Like usually we think about something which you can see on imaging or something which you cannot see on imaging. So let's say if down the line we get CT scan or some kind of bone imaging, and we see that things are going on there, like there is a mass there is some kind of lytic bone lesions there, then suddenly you start wondering that like maybe it is now time to unify. Maybe we are looking for something systemic in the body, hematological, which is affecting your bone, which is affecting your nerves, which is affecting your angioedema pathway by like various multifaceted mechanisms, right? So I'm keeping at back of my mind that how am I going to integrate this hip pain either through the bone pathology or the nerve involvement, either through alcohol or some other systemic process. So that is how I am uniting all of this, and examination will help us a lot. What do you think, Dr. Singh? Any other things you had in mind?
Yeah, absolutely. I think this angioedema is a great hypothesis, and then just looking for clues. Is it something that's allergic or non-allergic, and then following down the pathway. I think you're onto something like with the non-allergic cause. Here we do think about bradykinin as a possible contributor. The knee pain, if you think about what do you have in the throat and well, not in the tongue area, but in the vocal cords, you have cartilage, right? So cartilage is in the knees. Is this something maybe linking this? I don't know, but let's explore. We'll send the mic back to Siva for the next aliquot.
Awesome discussion about the whole Bradykinin mediated pathology. Yeah, coming to third aliquot. On examination, the patient was afebrile and hemodynamically stable. There was a right-sided tongue swelling and swelling of the floor of the mouth. There was no cervical, submandibular, or axillary lymphadenopathy, and remainder of the head and neck examination was normal. Extremities were normal on inspection. Cardiovascular system pulmonary exam were unremarkable. He had no hepatosplenomegaly or abdominal tenderness. There was a cirrhosis of his skin in the bilateral lower and upper extremities without breakdown or erythema. A small bruise was seen over his right knee in the prepatellar region. There was left olecranon bursitis without tophi. No synovitis in any joint. He had full range of motion except at the right hip. Motor strength was 5/5 in all extremities except that right hip flexion and extension could not be assessed because of severe pain. There was tenderness over the lateral aspect of the right hip and pain with Faber testing, without warmth or swelling. There was no tenderness of the thigh. Examination of the back showed paraspinal muscle spasm. There was no pain with straight leg raise and no focal sacroiliac tenderness. I will stop here.
Perfect. Thank you, Shiva. So, friends, just to focus on what we are dealing with. So, we are talking about a middle-aged gentleman who has significant alcohol use disorder, who is presenting with looks like a chronic pathology, which is affecting the oral structures, causing tongue swelling, something the articular structures affecting the hip joint, and probably neurological structures causing neuropathy as well, right? So, we are interested in examination, and we are wondering that what we will find in the oral examination, right? And looks like what hypothesis which we laid down probably seems to be holding true so far, that we have the right-sided tongue swelling and swelling of the floor of the mouth. So we were saying that if you have swelling in the one part, maybe the contiguous structures will also be involved, and the floor of the mouth certainly kind of adds to that suspicion, right? We didn't hear anything about obvious trauma, like we didn't hear that there is an aphthous ulcer, there is erythema, there is necrosis. So kind of exogenous agent makes less sense, and we are more worried about the endogenous process, which is diffusely affecting the soft tissue of the oral cavity itself, right? And then talking about this hip joint, we see some dramatic findings. We are seeing that I mean the fonts are so small, but let me see. There is like tenderness and there is limitation in the range of motion, right? So which always raises the issue that this is affecting the articular structures, right? Because if there is like just so much pain but the range of motion is preserved, you might focus more on the extra articular structures, that something is wrong with the ligaments, tendons, your bursas, your muscles, right? But when directly the active and passive both is involved, you have to entertain that joint is involved. And why? Because that is more dangerous process. Like think about all the processes which can affect your joints directly: septic arthritis, inflammatory arthritis, neoplastic arthritis, or direct involvement of the acetabulum and the femur, your pelvis, like lytic bone lesions, like metastatic cancers, right? Like myeloma, things like that. So often, since it is so sinister, you have to entertain those pathologies earlier. And down the line, if you are wrong, I would be happy to be wrong, right? Because if patient has something in the muscles which could be fixed easily, well enough, right? But if we miss a joint pathology, then it would be dangerous for the patient, right? So in this process, in this case, so far, I'm more worried about direct involvement of the osteoarticular hip joint itself, right? Now, how to make more progress? So one comment which I wanted to make, which I forgot in the previous record, was that if you look at this gentleman's past medical history, it's interesting, right? That patient had 2 episodes of COVID and shingles. Now, if rather than COVID and shingles, if it had been written that patient had 2 episodes of flu over past few years, you won't be worried, right? Because everyone gets flu. Like I'm having flu right now, right? Like that's why that's why my voice is probably a little bit hoarse, right? But shingles, very unusual. And especially at this age, if you are like 85 years old, you get a breakthrough shingles, I could understand. But at the age of 50, very unusual, right? And that also raises the question that are we dealing with something more systemic, which is affecting your immune system at the core level, impeding your ability to generate enough antigen, antibody, immune responses, right? And that is why what hypothesis which were initially wondering that is there something hematological going on which is affecting your nerves, affecting your bones, affecting like generation of variety of antibodies and cytokines which are affecting the bradykinin pathway, right? So that hypothesis definitely gains momentum when you see that someone had 2 episodes of shingles, and if Shiva tells us that oh patient was vaccinated and still they got it, even more suspicious, right? So we will see what the BMP shows, like if we have signal that your bone is getting destroyed in some form, or if we have signal that your electrolytes are deranged, if your like CBC is showing that some of the cell lines are down, maybe there is some kind of inflammation, then that would be very concerning, right? And regarding other pathways which we want to evaluate so far, so we will need imaging of your hip for sure because you're worried about the articular process, right? So like as we have seen in the prior VMRs that X-ray is a good imaging study if you are working in the ED and if you want to make the quick decision. But if you have time, like we have often as an internist, that this process has been going on for 2 months, right? So why to get an X-ray? Like probably we should say that we are looking for a bony process, then we should get the CT scan right away, right? So in this case, I think CT of the hip joint, like sacroiliac and the pelvis, would be the ideal way to figure out that what is the articular process which we are dealing with. And based on what we find, we can generate our hypothesis more, right? Regarding the neuropathy, I think on examination, we didn't hear about the motor weakness. So probably this is just sensory issues going on so far, but at least basic vitamin levels, like you look at the nutritional labs, I think that is reasonable. Checking an A1C, checking the thyroid, like the basic metabolic workup. And based on if all of that is negative and our suspicion persists, we can pursue the second line of thinking, which would include checking for paraproteinemias, right? So that is how I am putting all of this together. And maybe I can pass mic to Dr. Singh to highlight other things and also the tongue swelling workup, which he wants to pursue.
Sorry, I think my computer has flew. It keeps blanking off and I can't hit the unmute button, but luckily it showed up. I'm gonna have to reboot after we get off. So if I indicate if it's not working, just go to the next aliquot. Okay, yeah. There's a lot to unpack here. You just went through a whole like sequence of trying to link all of these different things. If you look at what we have, we started off with this tongue issue. You add to this formula anaphylaxis. We talked about bradykinin mediated. You know what's interesting? Like bradykinin mediated, you don't really need a stimulus. It could be just stress, right? And the body right now appears to be stressed. What is that stress? Inflammation. So maybe this is a bystander and is triggered by whatever stress the patient is having. You have multiple different tissues that are aligning in this process. We have skin, we have joint, we have nerve. Like you had mentioned, we still don't have the laboratory data, which will be interesting. You mentioned maybe paraproteinemias when you have neuropathy and you have maybe this kidney involvement, maybe you have anemia. Maybe this is a paraproteinemia, which is interesting. It's too kind of premature to jump into maybe a particular hypothesis, but I think what we're going to have to do is kind of still very foggy at this juncture, and getting labs will help kind of decipher which way we're going to point our diagnostic compass. But you know what's interesting? I can't help. There's certain, what do you call it, conditions that kind of come into mind. Tongue. I was thinking, amyloid. When he was like elaborating the case initially, I was thinking, what if this is macroglossia? What if this is like due to amyloidosis? Knee. I don't know. The skin is also this xerosis, this dryness. This kind of have an autoimmune connective tissue disorder flavor. But I guess we'll see. We'll move on to the labs and see where we can sort of gain some momentum with this case. Back to you, Siva.
Great. I just wanted to touch on one point. Like right now, we are going through mostly a bradykinin-mediated pathology. So in terms of this patient, his first episode prime, which is not in the case for bradykinin-mediated. So can you both of you talk a little bit about management here? Like if we think of bradykinin, he shouldn't respond, correct?
Yeah, that's a good point, Shiva. So, like, as we are saying that we will go through that pathway at that point because that's like the most obvious, but we will definitely, with the labs, we are planning to say that could this be other process, like maybe histamine mediated, right? And maybe more systemic immune stuff, because if you think about it, that after all, bradykinin and histamine both are stored in your mast cells, right? And not just mast cell, other myeloid lineages as well. So sometimes people can respond to like epinephrine, steroids, because this gentleman responded to steroids, right? So we know that steroids will non-specifically exhaust and affect all your cells, from myeloid lineages to the lymphoid lineages, right? Like B cells, T cells, everything. So sometimes it may not be, how to say, clear that what kind of process we are dealing with, because steroids will non-specifically improve everything, and that is the reason why in so many people with anaphylaxis, just like normal anaphylaxis, let's say you have some allergy to, like, let's say peanut allergy, and you get anaphylaxis, although we know that the drug of choice and the drug which will really make impact is only going to be epinephrine, but still you will see that in emergency department people will get cocktail, people will get like antihistamines like H1 blocker, H2 blockers, and steroids, because they say that steroids are not going to do harm, then why not give it, right? And oftentimes what happens is that there is this phenomenon known as biphasic anaphylaxis, which means that you can have anaphylaxis after having peanut, but then after 6 hours or 7 hours you can have another episode of anaphylaxis even without eating anything else. So oftentimes people believe that corticosteroids have some role, although it's controversial, they have some role in preventing the biphasic anaphylaxis. And I wonder, probably that is the reason why some of our ED providers and some of the internists try to just give anaphylaxis, especially if you think that patient won't be able to make it back to the hospital because they are living far away, right? Then they give steroids. So that is my like sense of thinking about that. What do you think, doctor?
Yeah, luckily my computer came back on again. But yeah, that's a very interesting question. I didn't really think about it because my mind is so swirling. It's a lot of details in this case, yeah. But if we stop at that juncture and think about it, yeah, Ketan, there is this acquired sort of angioedema that you can get, which is mediated by antibodies, right? So if the antibodies attack, I don't know if it's C1 esterase, these antibodies could emanate from certain conditions. I think lymphomas, maybe lupus. So if that is the pathomechanism, steroids in that case will at least put a damper on this autoimmune mediated bradykinin mediated angioedema. So that is, maybe we are dealing with something along that line there, but something to think about. So we see less of it, but that's something to think about, because again, how is this affecting all these different tissues? I think we have to look at it through an autoimmune lens. Any ideas about that? Anything else, Keaton? We'll swing the mic back
Dr.
to.
Singh, yeah, let's.
Wonderful.
Great
And like,
discussion.
yeah, like you mentioned, also hematological processes. So yeah, that's a great, yeah, that's a great idea. Back to you, Siva.
Great discussion. I like the way the discussion is going on. Thank you. Coming to the fourth aliquot, I will reveal the labs. His CBC, his hemoglobin is 11.6, hematocrit 35.7, and MCV 88. WBC 6.9 with normal differential 194. It's a normal, creatinine 1.1, magnesium was 1.5, A 23, albumin total protein 10, and then ESR is 113, CRP 1.8, CK is 104, uric acid 8.6, urine analysis is normal, urine drug screen negative, ANA is 1:320, and I'll give the imaging as well. Radiographs of the hands and wrists showed multiple osteophytes, subchondral sclerosis, and narrowing of the carpometacarpal, distal interphalangeal and proximal interphalangeal joints. There was a possible erosion at the third right MCP. And a radiograph of the right hip showed thickening at the femoral neck, interpreted as consistent with the femoroacetabular impingement, and enthesophytes at the anterior superior iliac spine and greater trochanter. I will stop here for the further discussion.
All right. We can split this up, Kirtan. I'll start off with the hematology and chemistry. You can hear me, right? All right, good. Again, my screen is acting up, but yeah, what does this tell us? Actually, the CBC chemistry doesn't really tell us a lot here. CBC, I was looking for maybe a signature when you have inflammation, you may have a downturn in the cell line. So the anemia is not too terrible. The platelet count is normal, and the white cell count is not too active. So normal, not a lot that it tells us, but we can kind of deviate from maybe a primary hematological issue. If the white count was 100,000, maybe somebody was alluding to in the chat there, maybe this could be leukemia or maybe hematological malignancy causing this. Chemistry is here. What's interesting. Thanks for putting all the abnormal labs in red. So kidneys are normal. That could be a powerful signal for something like a paraproteinemia mediated issue here. The magnesium's low, but the uric acid, I don't know really what to make of it. Uric acid in this case, we tend, it's one of those things we do for no reason. Really, is it going to help us if it's exaggerated, severely exaggerated? Could it be an indicator that there's a lot of cell turnover? So we do tend to see this in certain conditions like tumor lysis syndrome, but here it doesn't have that much relevance. Looking at the albumin, it's down. This could be purely due to inflammation. And it does appear from the narrative that's been said here, this patient is vastly inflamed, as we can also see from the SED rate. SED rate is above 100, and that does indicate that there's a lot of like material within the blood that's just dragging it down when they go to spin it. So total protein is high. That means there's something in the blood which is also maybe causing the albumin to turn down. And then that might be with a key where we need to focus our attention on what exactly is that protein where it's severely high. We can call this the gamma gap. What's interesting, just shedding a light back on the past history, COVID, shingles. So this patient has been in a hyperinflammatory state before. Could this be a post-COVID sort of situation? Not sure, but it can prime your immune system for other conditions. But that definitely, I think, is something to direct us in what's going on. So I would go down the route of doing SPEP, UPEP, light chains, and then just have a look there. And then there's a lot of signal within the imaging, and I'll tell that over to Kirtan for discussion.
Yeah, no, Dr. Singh, I'm right there with you. Like what we were discussing in the previous aliquot, that maybe we are dealing with a systemic issue which is affecting your articular structures, your nerves, and is also causing angioedema kind of pathology because of deranged cytokines and antibodies, right? And then we also said that like COVID and shingles is like unusual to have multiple episodes at such a young age. And also like just wanted to share you one fact as well, that if you think about it, often the people who have myeloma and who are getting the standard therapy, we call it as the CyBorD regimen, which is cyclophosphamide, bortezomib, dexamethasone, with or without daratumumab. Oftentimes these people are given shingles and valericyclovir prophylaxis. So, and these indications are pretty selective to the myeloma itself. We don't give shingles therapy to someone who has leukemia and who's going chemotherapy. So that kind of tells you, right, that how important it is that your plasma cells and B cells are generating the immunity against your VZV, particularly shingles. And that is why we give vaccines before we ablate the whole plasma cells in someone's body with CyBorD regimen, right? So that again adds to our suspicion, right, that something is going on. And now we have like very like clear evidence that you have high ESR, almost normal CRP. We often talk about ESR CRP patterns. We know that in real life, it may not be always applicable because things are complex. But when you see such kind of discordance that CRP is completely normal and ESR is super high, like what Dr. Singh was saying, that something is in your blood, right? And we know that it's the globulins which increase the sedimentation rate. So whenever the globulins are high in number, doesn't matter whether it is polyclonal versus monoclonal, will raise your ESR, right? And similarly, if you think about like the gamma gap is pretty like dramatic. So that adds to that suspicion, right? Now, if you just try to think about any alternative possibilities which we have at our hand for this much gamma gap, usually such gamma gap is seen in the setting of chronic infections. So let's say if someone has HIV, hepatitis B, hepatitis C, then since there is chronic immune activation to fight against this infection, often you get polyclonal hypergammaglobulinemia, right? We don't have evidence of that yet, but it is reasonable to check for all those infections, HIV, Hep B, Hep C, because they are common infections. You don't want to miss them, right? Second thing, that do we have evidence of overt cirrhosis? Because oftentimes in cirrhosis, what happens is that since you cannot produce albumin, your body compensates by producing more globulins, at least in the initial phase, right? So oftentimes you will see so many people with cirrhosis who are in the hospital, they will have increased gamma gap, and almost always that gamma gap will be polyclonal in nature, right? So these gentlemen who have significant alcohol abuse, one might do imaging down the line to see that could this be cirrhosis or not. But still, you should always be skeptical when your gap goes above 6. So if you think about this, our albumin is 2.9. So if you consider it kind of like 3 and then 10, so it's like definitely over 7, almost it's like 7.5, right? So that is a very significant gap to be attributed just to like cirrhosis itself, right? If you think about something else, like does this person have evidence of chronic inflammation as such? Like, are we thinking this gentleman has, let's say, tuberculosis, some endemic mycosis, some endocarditis, like all other chronic causes of inflammation? We don't have any of those clues, right? And then finally, you go to the neoplastic bucket. So in the neoplastic bucket, like if you think about non-plasma cell disorders, like if you have lymphomas, like very aggressive lymphomas, and some indolent lymphomas who have been in your body for a long time, they might generate enough immune response. But usually you tend to expect some degree of symptoms like night sweats, weight loss, fevers, because the reason why you are so many gamma globulins is because you have cytokines, you have immune system activation, then that should reflect into your symptoms as well, which we are not seeing, right? So that is why the plasma cell mediated disease gains even more momentum, because even without causing overt B symptoms, directly by their pathogenesis, they can cause so much generation of monoclonal proteins. And if you see the monoclonal protein on the aspect immunofixation, then that would be another kind of point towards this hypothesis, right? Regarding the osteoarticular structures which we are seeing, it's hard to say, because as we said in the first part itself, that if you get the wrong imaging, you will never get the right diagnosis, right? That when you are looking for something pathologic in the bones, you want to get the CT scan or MRI down the line, right? Like X-rays are not going to be enough to look at the cortical structures of the bone itself. Like X-rays are just telling you that this gentleman maybe has some degree of osteoarthritis because of carpometacarpal joint involvement, DIP joint involvement, right? You see some erosions here and there, which could be related to the gout itself. Like we know this gentleman had a history of podagra, like in the toe, uric acid is high, alcohol history is there. So you have all the signs and symptoms which could direct you towards that pathway, right? So this joint imaging doesn't help me much, because it just tells me that there is another layer of complexity to this case, which is likely unrelated to what is going on in your tongue itself, in your neurons, like in your nose itself, right? So like Dr. Singh said, we would still like to pursue the SPEP and immunofixation along with the free kappa lambda ratio. And then now that we are at that point, maybe I can also briefly touch upon the fact that what happened to this angioedema stuff, right? Like, what are you doing for that? So as we are saying that bradykinin versus histamine, right? Like if it was a histamine mediated process primarily, then you should expect more pruritus, more itching, right? More rash, which we are not seeing, which doesn't exonerate it, but makes it less likely. And in the bradykinin, we always think about like hereditary angioedema, which is like from C1 SRS inhibitor deficiency. And the way you can quickly screen for that is by looking at the complements. Like look at the C3, look at the C4, right? But then we have also something known as acquired angioedema, like what Dr. Singh was saying initially, right? That you can have antibodies against C1 SRS inhibitor. And the way to differentiate between them and hereditary is by looking at the C1q levels. Because in hereditary angioedema, what happens? Your C4 is low, C3 is normal, C1q is normal. In acquired angioedema, you actually have C4 low, C3 will be normal, but your C1q will also be on the downside. So I think complement levels will be very illuminative to kind of push us towards that pathway. And then, of course, there are other nuances to the acquired angioedema. There are other pathways like involving coagulation factors like factor 12, which can cause angioedema. But the first point is getting the complements and SPEP, and then we can make more progress. What do you think, Dr. Singh?
Absolutely. Yeah, wonderful job there. Yeah, I think, yeah, we're both aligned in this, in trying to figure out what's going on here. And yeah, proteins are at play, a monoclonal process, probably. You did mention polyclonal, but I think those antibodies that can have an association with this acquired angioedema. And then with the skin manifestations, I know somebody mentioned poems is an interesting phenomena that could explain, but I would consider not there would be true edema rather than angioedema. But I think it's within that whole pantheon of paraproteinemias which can have that association with acquired angioedema. But I think, yeah, we need the next bit of data to see. You know, one other thought that came across was scleromyxedema, where you can get the skin, the joint, you have association with paraproteinemias. But I think we'll have to sort of run the whole gamut of paraproteinemias from the SPEP and UPEP and light chain data that hopefully Siva has for us. I'll turn the mic back over to Siva.
We have done serum tryptase, came back negative. Infectious evaluation was performed, respiratory viral panel and serological testing for HIV, syphilis, Hep A, BC, Parvo, B19, Mycoplasma, and ABV, which came back negative. Quantiferin TB gold testing was negative. Now coming to the complements, yeah, his C3 level is normal, C4 is low, C1 inhibitor antigen normal, C1 inhibitor function low, and C1q was low. And we also did other antibodies, that is anti-double-stranded DNA, SSA, SSB, Smith, RNP, SCL, 70 centromere, Jo, RNA polymer 3, all came back negative except for SSA. SSA came back positive, and then P-ANCA came back positive, MPO PR3 negative. And coming to immunoglobulins, IgG is 218, which is low. IgM is 7, which is low. IgA is 6,400, which is high. Because of his dry mouth and occasional oral ulcers once or twice a year, one second. Yeah, due to his back pain, a CT scan was performed, which revealed 3 compression fractures in his thoracic and lumbar spine. Vitamin D was checked, which is 17. And yeah, that's where I will stop. I have one more last report which will reveal the diagnosis.
Well, well, friends, we got our favorite test, SPEP, right? I mean, I can't tell you how many times I have sent SPEP and immunofixation on my patients. So many times. Anyone has normocytic anemia, SPEP, right? Anyone has some weird neuropathies, SPEP. So I just love that test. I know that it's not like that helpful. Sometimes you need to be more conscious in when you order it, but in the right setting, it can be helpful. So like we had a very good story for this even before like we had the gamma gap. And with the gamma gap, there is no way you won't get it, right? So now we have the SPEP results and very striking. Why? Because imagine that at one point we were saying that could this be polyclonal? So if it is polyclonal hypergammaglobulinemia, usually all the levels goes up, IgG, IgA, IgM. So whenever you see selective dominance of one paraprotein over the other, it is very telling that maybe that paraprotein is driven by clonal process. Also, it is very unusual for a systemic inflammatory process to cause IgA elevation because almost all the systemic process, like think about HPV, think about HCV, endocarditis, tuberculosis, other solid tumors, all of them actually causes IgG elevation more than any other proteins, right? So the fact that in our case, everything is low, but IgA is like so high, 6,400. It's like, I think the upper limit of normal of IgA is less than 1,000. So this we are talking about almost 6 times the upper limit of normal, which is very suggesting that we are probably dealing with a monoclonal IgA paraprotein rather than the polyclonal, right? And also, as we were saying about the angioedema pattern, that if this was really hereditary angioedema, then your C1q functioning should be normal. And also it would be a little bit unusual, if not impossible, for hereditary angioedema to present at the age of like 48 or 50, right? So the acquired angioedema makes more sense. And the C1q levels being low and the C1 inhibitor antigen being normal almost seals the diagnosis for this being acquired angioedema, right? Because like if it was hereditary, your C1 inhibitor antigen level itself should be low, right? So now the question becomes that I am framing this process. Now the tongue swelling is out of the equation because we know that tongue swelling is from the acquired angioedema, right? So the problem should be now older gentlemen with acquired angioedema, with peripheral neuropathy, with compression fractures, and on the background of recurrent episodes of shingles, right? Why compression fractures are important? it's always reasonable to check for metabolics, right? You check your phosphorus, you check your calcium, you check your PTH, you check your vitamin D. Now, vitamin D 617 is low, but it's not too low. Like, and to be honest, since vitamin D, like there is lots of controversies about, 25 hydroxy vitamin D, like how we measure it, how it is influenced by other processes in the body. So it would be unwise if we put all our money on vitamin D itself and say that, oh, you know what, your vitamin D is very low. Maybe that's why you're getting compression fractures, right? That would be unusual. So I would still try to probe deep, like what you were saying initially, that if you're suspecting a bone pathology, get the test which matters, right? So we got that test, which is CT scan, and we found that something is wrong, like compression fractures in a male, like why at this age, right? So you have to consider them as pathologic fractures, and you have to understand that how paraproteinemia as myeloma, either by direct invasion of the bones or by the associated cytokines, classically IL-6 and TNF-alpha, which are known to activate your osteoclasts in general and which are known to cause fragility in your bones, could be the reason why this gentleman has compression fractures. And of course, like alcohol abuse may be compounding it by lowering all the nutrients and all that things, right? Like tubules are not functioning well either, looks like from the low magnesium, high uric acid, right? So I think if we put all of this together, there's very high suspicion. So I think the next diagnostic test could be like immunofixation, which will show us if there is monoclonal protein, and probably the skeletal survey, or nowadays in the myeloma guidelines, people go directly for the MRI or the whole body PET CT because they are more sensitive than the skeletal survey in identifying the discrete bone lesions, right? So I think that is where we are heading. What do you think, Dr. Singh? Any other hypothesis you have?
Oh no, I just love the train of thought here. Just to sort of roll it back to the initial aliquot. If you think about it, when you have multiple different complaints, so multiple different systems, you can't help but start thinking of conditions where nerves, tissue, the hematological system, the bones, you always have to start thinking like, could this be? And it's kind of early in the process, but yeah, could this be a monoclonal polyclonal gammopathy, which clearly it is here. But this is interesting. I haven't thought about this acquired angioedema. This is something else that I think everybody's learning is we're marrying this now to the paraproteinemia or the family of paraproteinemias. And like you wonderfully described the process with the labs, we got the low C1q, which was greatly diminished. So yeah, we go. IgA is kind of unusual too, right? I like you mentioned IgG. We usually see with multiple myeloma. So we'll see. Is this the answer, or do we have to define the condition further? We'll swing it over to Siva for the next aliquot. You're right. The sequence of events. We do have to get the immunofixation. Over to you, Siva.
Great discussion. I wanted to ask, like, how are you factoring in the dry skin and here SSA positivity with SSB negative? The patient doesn't have any dry eyes.
Yeah, go
What do
ahead.
you think, Dr. Singh?
Yeah, I think it's noise. What's interesting is just you start with ANA, and it is the entry point to which we define a lot of autoimmune phenomena. But a lot of the population can have positivity, and like we said, this patient's immune system is primed, so you can have multiple different antibodies that are positive. They may not indicate the true disease, but there can be a lot of positivity. I mean, I may be wrong as well. This could point to a unifying diagnosis, but you got to be careful if we go down the rabbit hole of these conditions. You're right. The patient is having just one of the criteria for diagnosis of some of these conditions, but you have to also look at the clinical presentation as well. If it doesn't fit the antibody, I mean, the antibody by itself won't diagnose the condition. You have to have the whole full basket of conditions plus the antibody testing. Anything else, Kirtan?
Right. So no, Dr. Singh is absolutely correct that oftentimes what happens is that Sjogren's is one of those diseases which can have systemic flavor, but Sjogren's is also known to be one of those diseases which often coexists with so many other autoimmune diseases. Like often Sjogren's is associated with RA, SLE, and also with lymphoma. So in this case, if you think about it, like what did we say? That we just said that we at least need aspect to first figure out. But if you think about it, aspect is not going to be the endpoint diagnosis because let's say if aspect proves that you have monoclonal IgA, your job is still remaining to figure out where is that monoclonal IgA coming from, right? Because myeloma or plasma cells are not the only pathology in the body which causes monoclonal protein, right? We know that there are other diseases which can cause monoclonal protein, and most important one is the lymphomas, right? Classically, the B cell lymphoma. So, for example, lymphoplasmatic lymphoma like Waldenström is one example, but that should cause IgM. But apart from Waldenström, if you think about other lymphomas like mantle cell lymphoma, marginal zone lymphoma, these are the two low-grade lymphomas which are notorious to cause monoclonal protein elevation, and sometimes it can be very, very high as well, right? And why it is important in terms of Sjogren's? Because if you think about it, Sjogren's is in a way chronic activation of your lymphocytes. And that's why Sjogren's has so many diseases which are associated with lymphocyte activation. Like people with Sjogren's tends to have lymphocytic interstitial pneumonitis, which can end up developing into something like maltoma, which is in a way extranodal marginal zone lymphoma. And Sjogren's is also associated with systemic lymphomas, right? So that is why in this case, like SPEP is like just the next best step because of it can explain everything else mechanistically. But like anatomically, where is that monoclonal protein coming from? For that, we will definitely need the bone marrow. If it shows clonal plasma cells, let's say more than 10% in the bone marrow, you have your answer that this is likely IgA multiple myeloma. But if you don't find that, then as you are saying that whole body PET CT, because that can tell us if there are other lymph nodes anywhere else which you can biopsy and which will show you if this is like marginal zone lymphoma, mantle cell lymphoma, or other B cell lymphomas related to the Sjogren's as the unifying diagnosis of monoclonal protein, right? So that is what I was thinking. Anything else, Dr. Singh?
Oh no, yeah, wonderful overlap with those conditions. I think we still are not clear on what's going on, but I think let's do the first bit of legwork, see what's going on with the proteins, and then look at the possible autoimmune phenomena that could tie into this. Over to you, Siva.
Awesome discussion. So the SPEP that you're asking for, SPEP with immunofixation, the patient M spike is 4.1 gram per deciliter, and on electrophoresis it detects two IgA kappa monoclonal components, one in beta and one in gamma. And we have done a bone about 80% plasma cells. There are no plas. As you both of the start, the diagnosis was acquired C1 inhibitor deficiency as multiple myeloma.
Dr. Singh, we did it. How does it feel?
Oh, definitely learned a lot. This was great. This is definitely a journey. We've been through this paraprotein. I think we've done this before, but to then tie this acquired angioedema, that's I kind of read about it, but this is the first time I've seen it on VMR. Excuse me. So there's something I definitely will remember for a long time. I really appreciate you bringing this case, Siva, and also Jeffrey. But I think this is very educational. This is the place we come to learn and also get tested quite a bit. But any reflections, Kirtan? This definitely was fun.
Yeah, it was so much fun with you, Dr. Singh, as always. And yeah, a special thanks to Shiva because like he was not just presenting the data to us, right, but in between he's prompting us that, hey, what do you think about histamine? Like, what do you think about epinephrine and steroids being effective, right? What do you think about like this IgA? So thank you so much, Shiva, for prompting us to think in between so that we don't prematurely stop into one particular diagnosis. And yeah, like very important case and very fascinating, right? Like how one paraprotein can like trash your body completely, cause so many pathogenesis, right? And subtle clues everywhere from imaging to nerves to like past medical history, infections and everything. So such a neat case. So we thank Jeffrey as well. And yeah, now I will pass. And thanks to like Simi for helping with the scribing. There was so much data. So thank you, Simi. And then I will pass the mic to Dan Mahal for teaching points.
Yes. So very briefly, this is time. We started off with a neurologic issue, and we mentioned that time frame and localization are the two most important things to factor in when we're dealing with a neurological issue. We also talked about the speech generation pathway that begins all the way in the brain, from the Broca's area, going to the subcortical structures, cranial nerves, neuromuscular junction, and and the issues that could happen at the local organ, like the tongue, for example, or the trachea or vocal cords. And we mentioned that the physical exam can distinguish which part of the pathway and the history. And in this case, given the history, the speech dysfunction was more likely localized at the distal parts of this pathway due to the tongue swelling. And we also mentioned that shoveling snow generally is associated with exacerbations in cardiovascular issues and temperature-related issues, which wasn't really what we were seeing in this case. And in order to make a schema differentiate tongue swelling causes, we also mentioned exogenous versus endogenous causes, which could include autoimmune versus anaphylaxis versus angioedemas. At this point, we were also mentioning due to the NSAID use that bradykinin mediated processes might also be on the differential. We also mentioned that if in a 50-year-old, we can't attribute all the arthritis to osteoarthritis, and this could be a more systemic issue that's also causing problems in the joints, and that the joint involvement can have bad consequences. So we want to evaluate them early through imaging. Another clue that we had was the multiple shingles episodes, which at the age of 50 were unusual, which pointed us towards a potential hematologic problem. And through labs, we also got that there was a protein gap of more than 7, which can't just be from the history of alcohol use and the cirrhosis from potentially that. And would point more towards a paraproteinemia process from a plasma cell disorder. And at the end, we also talked about the differences between acquired angioedema and inherited angioedema, which are both a low C1 inhibitor conditions. But acquired angioedema can be associated with B-cell neoplasms. And the pattern of complements is different between the two, which we can use that to distinguish between them. And the distinguishing factor would be the C1q level, which would be low in acquired angioedema and normal in inherited angioedema. And after getting the IgA levels and the immunoglobulin levels and seeing that IgA is very elevated compared to the other ones, we also made the conclusion that this is potentially a monoclonal paraproteinemia, and that the systemic effects can be explained by both this paraproteinemia and the angioedema from the paraproteinemia.
Thank you so much, Dan Bear, for emphasizing all the key points, even the shingles point. So thank you so much. And again, thanks for joining, friends. Thank you, Dr. Singh. See you next time.